Hello, everybody. Welcome to this edition of the AVF Podcast, Behind the Scenes ICU Stories. And the topic today is the story of precision medicine in ARDS. Today, we are really glad to have Dr. Carolyn Calfee, who is a professor of medicine and anesthesia at the University of California, San Francisco, or UCSF, where she attends in the ICUs at Moffitt-Long Hospital. Her primary academic focus is the prevention, diagnosis, prognosis, and treatment of ARDS, and she's a key international leader with multiple high-impact publications on molecular phenotyping of ARDS and precision medicine in the ICU. Welcome, Dr. Calfee.
Thanks so much, and thanks so much for having me.
Thanks. Maybe we'll just start broad, and before we zoom into ARDS, could you share with us what precision medicine actually is?
Sure thing. I'll give you at least my 2 cents on it. So I think precision medicine is a fancy term for what we've been trying to do in medicine for a long time, which is to try to match the right treatment with the right patient, right? And we try to do that always to, understand our patient's diagnosis and then, use that information to determine the best treatment for them. And I think precision medicine is really just taking that to another level where we're trying to understand patients on a deeper level. Often the way the term is used has an implication around biological or molecular phenotyping, and trying to understand that patient's particular biology a little bit better so that we can better identify potentially effective therapies.
Right. You mentioned particularly molecular and biological, but say we talk about ARDS, there's also etiology and pathophysiology. Would you consider that precision medicine as well?
Yeah, that's a great question. I mean, I think people have been talking about heterogeneity within ARDS, which is what you're referring to, right? Differences in etiology, differences in physiology, differences in imaging patterns on chest X-ray. People have been talking about this actually since the term ARDS was first introduced in 1967. Even in that original case series from the Lancet, there were comments on the different etiologies, how some patients appeared to respond to PEEP and others didn't, how some patients appeared to respond to steroids and others didn't. So I think there's a tremendous amount of clinical heterogeneity that we've recognized for a long time. We could break that down in lots of ways by etiology. COVID-19 versus non-COVID-19 has sort of been the way people are thinking about that recently. Physiology, imaging, recruitability, all of these are different ways of clinically phenotyping our patients. And I do think you could consider that precision medicine in a way, because we're taking this umbrella syndrome of ARDS and we're trying to identify, okay, well, let me try to match my therapy to the patient's, specific clinical physiologic situation.
Right. So could you talk us through the rationale behind precision medicine in ARDS then?
Absolutely. Well, it really stems from what I was just referring to, is just this recognition for decades, really, that ARDS is not a disease per se, it's a syndrome. And within that syndrome, which is defined by empiric clinical characteristics, we know there's a very wide range of clinical features, but also a very wide range of biology, right? If we look at autopsy specimens from patients with ARDS, we see a lot of patients have diffuse alveolar damage, but not all of them do. If we look at plasma biomarkers in patients with ARDS, we see an array of different types of patterns. And so the rationale here is that, again, if we can understand discrete subgroups within that heterogeneous syndrome, that's sort of the first step towards identifying effective therapies. Right.
And you are, as I said in the introduction, a key leader in this field. You have got multiple high impact publications. How do you enter this field? I mean, most of us, we practice intensive care. We think about 6 mils per kg, high PEEP, low PEEP, but you actually went into the details, the molecular phenotyping, etc. What's the background behind that?
Yeah, that's a great question. Well, like many things in medicine, it goes back to wonderful, effective mentorship that I received when I was a fellow and in training. My fellowship program at UCSF had a very strong emphasis on doing research projects. And I connected with Michael Maffei, who's a world-renowned clinician scientist who does basic translational and clinical research in ARDS as my primary mentor. And he got me started on several biomarker related projects. He said, okay, well, why don't you try, first off studying, for example, trauma-related lung injury compared to other types of lung injury and how their biomarker patterns might differ. So that got me started on understanding what are these plasma biomarkers even? What's the evidence that they might be relevant to ARDS biology and outcomes? And then it got me started thinking about this whole concept of heterogeneity within the syndrome and how we could explore that biologically. And at the same time, I think advances in sort of data analytics and modern computing were coming along with the ability to do different types of unbiased statistical analyses to detect clusters or subsets in large data sets. And so it was sort of the confluence of that amazing mentorship that I had with the ability to start implementing some of these new approaches to data analysis that, got me very lucky to get started in this area.
And can you share some of your key findings from some of your main papers?
Sure thing. So, a lot of the papers that our group has done that have, I guess, garnered the most interest and attention have been where we applied this technique called latent class analysis to clinical and protein biomarker data from patients with ARDS. Latent class analysis is kind of a mouthful, but you can think of it as basically trying to identify more homogeneous subgroups within a heterogeneous group of patients. So latent just means hidden, right? And so it's like you're finding hidden subgroups. And basically what we did was to take clinical features of patients when they were enrolled in ARDS randomized controlled trials, along with a set of plasma protein biomarker data, feed that into a computer model without any data about what happens to the patients, right? Just the data that you have when the patient enters the trial. And say, okay, just with this data, like these were patients all in your ICU, can you find us hidden subgroups? Is there statistical evidence that there are hidden subgroups? And so now we've done this in about 8 or 9 different large cohorts, and we find a very consistent pattern across these cohorts, which is that we consistently find that a 2-group or a 2-phenotype model is a better fit for the data than just a 1-group or a 1-phenotype model. And that this 1 group, which constitutes about 30% of most of the cohorts we've studied, and we've called it hyperinflammatory, though I put that in quotation marks, has higher plasma levels of inflammatory biomarkers, more shock, more acidosis, and then consistently across all these cohorts, much worse clinical outcomes. So that's really suggesting that there are these 2 distinct groups that are pretty consistent and replicable across many different cohorts. I think why that has gotten more attention is because we've gotten really lucky to test these questions in the context of randomized controlled trials. And so then that allows us to say, okay, well, is there evidence that these 2 groups, which are identified before any treatments are administered, and then patients are randomly allocated to one treatment or another, is there any evidence that they respond differently to treatments, right? Because that's kind of why we care about this whole area of precision medicine or phenotyping, is because we're looking for treatments, right? All of our clinical trials, so many of our clinical trials are negative. And so we're looking for new ways to try to approach the problem. And we've observed that in several different trials, these phenotypes seem to respond differently to therapies. So they seemed to respond differently to high versus low PEEP. They seemed to respond differently to fluid management. And they seemed to respond differently to simvastatin versus placebo. And so that is, it's all secondary analysis. This all remains to be proven prospectively, and none of it should be applied to patients until we do get a chance to test it prospectively. But it kind of suggests that maybe there's this subset within our patients that we haven't been seeing because of all of the noise and all of the data. And there's been this group that is responding, but it's been drowned out by all of the heterogeneity. And so if we could find ways to identify that group prospectively, and target patients according to that molecular phenotype, we might be able to do a better job of finding effective therapies, at least for some of our patients.
Right, right. And so the hyper-inflammatory, as in HYPER in quotations, seem to respond better to higher PEEP, better to statins, and better to less fluids. Am I right?
To liberal fluids, but really what we tested in those trials was primarily, was there a difference in treatment response, right? We didn't actually statistically test the hypothesis that one class responded better or worse to a particular therapy. We just said, is there statistical evidence that the classes responded differently to the therapies? So that's really what we've observed so far. Actually determining what will happen when patients are treated prospectively is a whole different ball game, and why I always want to make it really clear that we shouldn't be applying these results for clinical care of our patients yet.
Right, right. And do you have any hypothesis? Because the response to PEEP or fluids or statins, aside from associations with biology, there are some associations with, as you said, imaging, as you said, etiology or physiology. Could we even possibly put all these different things together and come up with a hypothesis as to why molecular phenotyping is somehow associated with some of the above?
Yes, it's a lot of speculation, right? Because we don't actually know the truth, right, of why these respond differently. But let's take the case of simvastatin, right? Because that might be the easiest one to understand. We know that statins are not just, effective by lowering LDL cholesterol, right? And that's probably doesn't have much to do with how they might be beneficial in ARDS, but they have anti-inflammatory properties. They stabilize the vascular endothelium, right? So if you do have this class, and again, we don't really know if it's truly hyperinflammatory or if that is the most important mechanistic feature of the phenotype. We just see these elevated biomarkers, but let's imagine that it is characterized by more severe inflammation. We also know that it's characterized by higher levels of endothelial injury biomarkers like angiopoietin-2. So you could imagine that phenotype is perhaps going to benefit more from a therapy that decreases inflammation and stabilizes the vascular endothelium, right? So that's one hypothesis, is that there's really a better match between the treatment and the biology. Another possibility is that this hyperinflammatory phenotype is generally a more severe form of systemic critical illness that is also characterized by ARDS, right? And that because it's more severe and the outcomes are worse, we're in effect conducting prognostic enrichment by focusing on that phenotype. Now, the argument against that is that the direction of the effect for PEEP and for fluids is in opposite directions, right? So it's not just that you see no signal for a response to PEEP in the hypoinflammatory phenotype, it's that the response actually seems to go the other way, right? Another hypothesis is that the hyperinflammatory phenotype maybe is more akin to what we've been modeling for years in experimental models of ARDS, right? And so all these therapies that we test out in experimental models, we're sort of testing out in the hyperinflammatory phenotype. And the hypoinflammatory phenotype is more of a sort of mixed bag of, combinations of atelectasis and fluid overload and some lung injury, but lots of other things on top of it. And so we can't identify the signals that we see in experimental models in that group because it's so heterogeneous. So I could go on and on with lots of different theories for why this might be. But the true answer is that we don't know, and we're really probably not going to know until we start doing prospective clinical trials.
Right. And so for clinicians who are not doing randomized controlled trials, you think that it is not ready for prime time? It's like, I'm not going to start checking interleukins and TNF and then change my treatment according to that, no?
It's definitely not ready for prime time.
Right.
These are all, as excited as we are about these findings, these are all secondary analyses of clinical trials. You could also call them subgroup analyses, right? And yes, they are unbiased in a sense. And yes, we find these subgroups consistently across all of these trials. But there's a big distance between that and saying, okay, if we identify patients in real time on the basis of inflammatory markers or a machine learning algorithm that classifies the patients, and we treat them according to that classification, that will be better than what we're currently doing. Big distance between those two. So definitely not ready for prime time yet. But a fantasy would be that this might be ready for clinical testing in 5 to 10 years.
Right. And how about beyond ARDS? Does this apply to sepsis or the other syndromes in the intensive care unit?
Yeah, that's such a great question. So I think, the jury is still out on that question. We don't have definitive answers for it, but I think the answer is likely to be yes, because we know that all those things that I said about ARDS being a syndrome defined by clinical criteria, not a single disease state, et cetera, we know that all applies to sepsis, right? Very similar problem. We know there's a lot of biologic heterogeneity within patients with sepsis. Most of that work has been done on the transcriptional profiling level rather than on the plasma protein biomarker level, but we know there's clinical, heterogeneity in etiology. We know that there's biologic heterogeneity. And we're starting to see some signals from, for example, patients with acute hypoxemic respiratory failure, that similar phenotypes seem to be present in those patients too. So I suspect that what we'll know in a couple of years is that these are not phenotypes of ARDS per se, but they're phenotypes of critical illness and phenotypes of the response to, major infectious insult and injury. And that may help us try to understand some of those questions you were asking about mechanism, right?
Right. And the day you think that it may be ready for prime time, 5 years, 10 years, do you think that people in resource-limited countries can pull this off, say, just by looking at hemodynamics or bicarb, as opposed to having to check the different biomarkers that are sometimes not readily available?
That's such a great question. And I think that's really one of the major challenges in this whole field of precision medicine is how do we make these approaches that we're working on generalizable, available widely and broadly to people all over the world. So far, what we've done in terms of trying to develop classifier models for these phenotypes has focused largely on biomarkers, which are obviously, technologically not very difficult, but cost-wise may be difficult to generalize. So at the same time as we've been doing that work, we've also been working on developing classifier models that just use clinical data. So one fantasy would be someday you could have an app on your phone or an app embedded in the EHR that could take the clinical data available on the patients, which would be vital signs, lab data, things like that, and generate a probability of being in the hyperinflammatory phenotype. Because we've seen we can do this retrospectively. Whether we can do it prospectively remains to be seen. But I think that's probably the approach that would be most likely to be immediately translatable to, low and moderate income countries, for example, or places that don't have as many resources.
Right. And so what's happening in the research field now? What studies are upcoming and we can look forward to?
Yeah, so we're really focused on a few different fronts right now. So one is this question that you're getting at of how do we identify these patients in real time clinically? So we're testing out some real-time assays for molecular profiling of biomarkers like IL-6 and TNFR1 at the bedside. We're testing out and working to develop these clinical classifier models that might be able to allocate the patients without the need for blood work and an assay. And we're thinking about how to integrate those types of approaches into clinical trials to really test these hypotheses prospectively. At the same time, we're also working in a more translational space to try to understand the biology of the phenotypes better, to try to do deeper biological profiling of samples from blood, samples from the lungs, to try to see if we can identify more about what pathways really distinguish these phenotypes. You know, we have just a very superficial look right now at these protein biomarkers, but we want to go much deeper to try to understand, the biology there. And then finally, we're working on another question that you alluded to, which is, are these really phenotypes of critical illness? What happens when we look at patients with sepsis, acute hypoxemic respiratory failure, et cetera? Do we see these same patterns that are consistent? And how do we think about, on a conceptual level, sort of defining treatable traits or phenotypes that go across syndromic definitions of critical illness?
Right, that's really fascinating. Dr. Calfee, any last words you want to share with the audience?
No, I really just appreciate the opportunity to talk with you. I'm so glad that people are interested in this, and I'd be happy to chat with anybody over email that wants to contact me with additional questions, ideas, or thoughts for follow-up.
Right, thank you very much. I'm sure many people will be interested. I mean, ARDS, since 1967, we've been lumping them all into one big syndrome and really struggling to find treatments other than trying not to cure patients with our treatments. And so we really look forward to more results from your team. Thank you very much, Dr. Calfee.
Thank you so much for having me. It's been great to chat with you.
Thank you. And to everybody, this has been the AVF podcast. My name is Jason Poa. And if you like this, please feel free to share with your friends. It's available on YouTube as well as Spotify. Till the next time. See you. Bye.